Today is a grand round for the whole of the department, and the topic we're going to be talking about is communication skills. So judging by the number of people in the room, perhaps it's not the most popular topic. It's certainly not a clinical topic, many of you might think. But to be honest, these are the soft skills that are the hard skills. Communication skills are something that might trip up the best of us, that might get us out of trouble in the worst of the circumstances as well. So when we were given a brief by none other than the Chief Medical Officer that emergency department doctors need to improve their communication skills, we had a bit of a challenge on our hands because we were already incorporating communication skills in everything we do. It's incorporated in our assessments. We put that into every scenario or simulation that we run. We have that within our resuscitation. We feed back to all of our trainees during the clinical work in the form of workplace-based assessments. And we do run some lectures on it. But when, as a faculty, we sat down and started looking at communication skills, we realized we needed to do more than just have an understanding of communication skills. We needed to practice these skills in a safe setting amongst friends, and we needed to explore situations that are fairly unique to the emergency department. I think many of you have been to communication skills workshops run by the medical education department. You might have attended these workshops run in conferences, but many of them are fairly non-specific. You know, we have plenty of time, we can sit down over a cup of tea with flowers on the side, bleep switched off, no mobile phones, and have a leisurely conversation with a patient about a problem. But in our part of the world, it doesn't work like that. We all know that. We have major issues with the environment, with the busyness of the work that we do, and with issues that seemingly crop up out of nowhere. So we have a different set of issues in which we may have to modify our communication skills techniques to apply to that particular setting. So the idea of today is, instead of lecturing at you, we will make some interactive scenarios. So there are 4 scenarios that we're going to be talking about. We're going to be talking about history taking, which is very straightforward, but there are certain things in there that we need to focus on. We're going to be talking about de-escalation and negotiation with the patient. Then we want to explore around team communication, both within the teams and outside of the teams. So those are the 4 scenarios that 4 different faculty, quite senior faculty, are going to be running. And then we will invite your comments and interactive discussion that follows. So basically what we're doing is we're drawing on the expertise of experienced faculty. But firstly, what we want to understand is the patient journey that our patients go through in the emergency department. As I said before, it's not as straightforward as a medical outpatient clinic. So Dr. Ashid is going to kick us off with a 10-minute overview of the ED patient journey. So I'd like to invite Dr. Ashid to start. Thank you.
Right. Good morning. So, as Dr. Saleem said, I think when we talk about communication skills and when we are going to talk very uniquely about emergency department, I thought it's important that we sort of have an overview of the patient's journey through our department, and then pick up on some of those points where communication becomes important. So, all the 10 minutes, what I'm going to do is talk about a few sort of concepts of communication which are important in emergency department, and give you some tips on how you can make it more efficient. So let's look at a patient's journey. Any of our patients comes to emergency. So if you think about it, the patient has multiple encounters. He first sort of comes with a paramedic or by himself. Then there's a triage. Then they goes to a first emergency physician sees them. There might be nurses involved, there might be doctors involved, and then, especially in our department, the second doctor who sees them might be different. And then they have other specialities, then they might have they might be bounced back to you, but it might be a different doctor. Now, looking at this patient's experience, when he goes out of the ED, it's a collective experience of all these encounters. And when he asked him how did he feel, it's very sort of easy for him to say it has not been good. It's just one of those encounters was not good. And if you look at it from a doctor's your and mine perspective, each of one patient care might involve communicating with that patient, his family, other specialties, radiographers, nurses. So, I mean, it's all about communication. And earlier Dr. Saleem said, like, we think it's not important, or at least it's not perceived as clinical. But if you look at literature, rudeness or bad communication has been proven to be iatrogenic. It's one of, like, a common cause of complaints, we all know that, but it definitely is a common cause of poor patient outcome. Mortality, morbidity, everything is worse when the communication is not good. So, now, just let's look at why it is unique in ED. Right. It's unique in every way. If you think about a patient, he is there not on his best day. He's there not by choice. It's usually an accident. It's usually an unplanned visit. They're anxious. They are in pain. Or it could be they're embarrassed. They are coming to come and talk to you about something which they would prefer not to talk to anybody. All these things make them not at their best. And when you're not at their best, it's bad communication. Like when you're angry, you're not at best. You're impatient. So that's a poor start for a patient itself. Now think about the environment. Every literature you say, they talk to you about sitting the patient at eye level opposite your table, but ED, you don't have the choices. It's busy, the privacy is not there. You're going to talk to somebody about their sexual history behind a curtain, 3 sides there are other patients, there are people. So it's not ideal. And from a doctor's perspective, you're busy, you're interrupted multiple times, you're probably hungry, you're on the bathroom. Again, it's your 5th shift in that week. Again, you're not at your best, but for more or less everyone in this room, that's going to be the same for all of our life. And I think we really need to work around how to still do our best in all these circumstances. So, some general rules. Some of these are what we learned as a child, what our parents taught us. Be nice, first of all. If you are nice to somebody, it's very, very likely they'll accept what you say. It's more likely they will work with you rather than work for you, and the benefits are best. Be it the patient, be the other specialty doctor whom you want to refer your patient to. So the first rule, be nice to them and work with them rather than work for them if you look at patient's concept. The other concept, which sometimes is important for us, is being authoritative or being assertive, would be probably the right term. And this is important in some scenarios, especially like, for example, if you're team leading a research scenario, there's not much leeway for debate there, and you really have to learn to be assertive when needed. And that actually is completely different from being rude. So being assertive so don't take it like as the same thing. You really have to master the skill of assertiveness. Now, being assertive also takes preparation in terms of improving your credentials among your team member. And obviously that's something which you have to develop over some time. Now, state facts only. I had to put this on because a lot of times we see people, one, you got to state facts. You got to tell the patient or tell others what actually is it, because they have the right of information about their own care. The other thing is you got to state only what is true. Please do not exaggerate or even don't underplay things either. It's much easier to tell a patient, well, you might be waiting for 18 hours, and then your argument would be, if they get out in 10 hours, that's a bonus. But I don't think that is true, because as a professional, I think what you say has to be credible. Similar way, don't overplay it with your specialties, because again, it's not a one-off thing. You got to do it again. The other one of my big bugbears in like our hospital, it happens everywhere, is we stereotype people. I'm sure you all know about, they're talking about, oh, he's a Bengali, he's an Egyptian. I'll tell you my story. I mean, I came to Hamad about 3.5 years ago. One of my first shifts in male C&3. I was sitting in one of the front cubicles, and I saw this guy in a lot of pain. I wrote morphine, 5 milligrams or 10 milligrams, I can't remember. Those days I used to sort of write more morphine than diclofenac. And the nurse looked at me in sort of a disapproved way. It's like I was not sure what it was. I walked out of the cubicle and asked her, what's the problem? She said, he's a Bengali. Honestly, I was thinking, what have I done wrong? It's like, is our Bengalis allergic to morphine? I don't know. I was like, I didn't understand it. And then I asked her, what's the problem? And she said, well, they overplay their pain. So, but now so I can see where that came from, because it's very, very common. Why I'm saying that in the communication station is, before you walk into a patient's cubicle, if you are biased already, that's a poor start. I'm not just talking about bias on the basis of race, gender, or anything. Even if it's that patient who's come 48 times with chest pain and every time he's been discharged saying, there's nothing wrong with him. If you go with a preset agenda, oh, I'm going to see him and just tell him off, that conversation is not going to go very well. So just avoid having a preset thing. And then keep your conversations patient-focused. Now, why I say this? If it's not about your stand versus the other person's stand, especially in conflicts, or even with the patient, if you have an agenda saying, oh, this guy doesn't need a CT and I'm not going to do it, and if that is your first thing, and if that is your position, then that communication is not going to get very well. The same thing with referral. Unless you think this patient needs to go under medicine, and if you're not going to listen to the other person, then that communication is not going to go very well. Change your perspective, thinking, what is this patient's interest, or what is in this patient's best interest? And if you work towards that, I think it's much easier to negotiate. So, just dwelling on the same point which I was talking about, it's all about patient-centered care. We all talk about evidence-based medicine. What's evidence-based medicine? Anyone who can sort of remember the definition? Okay. We all think, it says most current evidence, but there's a last bit to that, which is in the best interest of the patient's views and needs, which is something which we sometimes tend to ignore. So actually, good evidence-based medicine is the junction which is scientifically correct, is in the patient's best interest, or is meets the patient's views and expectations. So it's important, if you have to practice good medicine, we need to find that bit of it. What is the patient's best interest, or what is the patient's view on it? That's where these concepts of ideas, concerns, and expectations come in when you take a patient's history or during your consult. You need to find what the patient's interest is. You really need to ask the patient, what are you worried about? What is your fear? And if you get to that, I can tell you it's much easier. He might be just there for a sick note, but it's important for you to know it because you can work around it then. I'm not saying then you can ignore the medical aspect of it, but you really need to find out what the patient's main interest is. Now, that doesn't really mean the patient gets what they want if it is not scientifically correct. That's where the concept of patient satisfaction differs from patient-centered care. We were having this similar discussion at the fellowship today about, you have a lot of patients who come in saying, I need IV fluids. Now, what's easiest for you is, oh, it's just a fluid, it's not going to do anything, or at least think that it's not going to do anything. Give the patient the fluid. or that patient who asks you for an antibiotic for a common cold. It's time saving, it's much easier for you, and it's less stressful for you, less work for you to prescribe that antibiotic or fluid. But that is not the right thing to do. But then what can we do is tell him no, but that's going to be difficult. So how do you do it? And that is the skill where it comes to sort of, persuasion. Tell the patient, find out what the patient's true interest is. Why do they actually want it? What are they worried about? If someone is asking for a CT scan, what are they worried about? What do they want to see if they've got or not? Like if they're worried about cancer, then you work around, tell him why you don't think he's got cancer if that's what you feel. Now, and it is important because if it's known that institutions which has chased patient satisfaction more than patient-centered care, the patient outcomes were worse. If you just want that smiley face ticked on the patient feedback form, it doesn't really mean your patient outcomes are better. They've even been shown to be worse as compared to other places where patient-centered care was a focus. Now, so once you have your patient's interest, once you know your patient's interest, it's much easier to explain to the patient, come to an agreement with what you're going to do with them or what you're going to do for them. Right, so just now, how do we do it? Now, communication, it involves a lot of things. Like, for example, if you want to make a point to the patient, it depends upon what you say, how you say it, what you do while you say it. These are the three main things. So these are the variables which you can actually change. But there are other variables like how you look, and there are other things like your authority. For example, if a nurse saying something to a patient and then you go and say you're the doctor or your consultant, that's more effective. But those other things have some effect, but you can't change much about it. What you can really change is your verbal, non-verbal, and paraverbal communications. The paraverbal is how you say it, it's your tone, it's sort of how much you listen, how much chance you give them to sort of explain their views, and then you feedback them. And what you say actually has only a 7% effect on how effective your communication is. 55% is your non-verbal communication, and 38% is how you say it, or your paraverbal communications. So, common things again, like I said, greet the patient, know what their name is, call them by their name if that is culturally acceptable, or say shake something, or Mr. So just greet them by their name, it's more effective. And then obviously tell them who you are, what your intention is. The second point is sharing your mental model. What that means is you tell the patient what is going through your mind about that patient's care. Give them as much information as possible upfront. If you have a patient who comes with a classic chest pain, and you know at that point you're not going to discharge him without your second set of troponin, tell him that you're going to be here for 6 to 7 hours. Tell him you're going to do a blood test now, you're going to repeat that blood test later. So give that information upfront. So then be empathetic, and then the next one is normalizing experience. That becomes important when, for example, you have a patient who's embarrassed about it. Tell them you've seen it many times. Someone who's coming with maybe a sexual history, a sexual disease. Say, you're not alone, you have seen it. It makes it easier for them. Non-verbal communications, it's your posture, it's smiling, sitting at the eye level. Some of these are difficult for our emergency department, but again, sometimes when you have a conflict, it's probably worth sitting them down, sitting at there, and having that eye contact. Again, how you look, that's something you can change. Make sure you look professional in every way. Have that open posture, appropriate eye contact. So, and finally, I had to include discharge because that's not something which you're going to cover in our stations. Now, our discharge advice, generally, even on the Western literature, people don't understand 1/3. And I think it's worse for us. I think probably only 1/3 of our patients understand what actually we tell them. So how can we improve it? You repeat it. You ask them to repeat it back to you. Now, there's a question, verbal versus non-verbal. What do you think is better? Oh, sorry, verbal versus written. Written? No, if you had to choose one. Written? No, it's verbal. The verbal works better. Hardly people read what you give them, especially if it's a long one. And then uncertainty principles. With that, I'll stop. Uncertainty principles is if you are not sure about a patient's out, like for example, if you're not sure, he still could have cardiac problem, but everything on your examination, everything on your investigation says that fit for discharge. Tell that to the patient. It's very unlikely you got it, but I can't be 100% sure. But if you have any of these problems, it still means that you got to come back as an emergency. With that, I stop and I'll let Dr. Suresh stop.
Okay, thank you.
So next I'd like to invite Dr. Kumar
To focus on history taking, a simulator scenario. 35-year-old gentleman presenting with a central chest pain with normal vital signs and his ECG normal, and he is being seen emergency and treat. We are going to have a look at the video for 5 minutes, and then subsequently I want active Okay, can you hear me now? Okay, so we're going to see a video for 5 minutes, then we'll have a interactive discussion and your feedback about what you guys see in the video, and we'll explore some of the concepts that's been discussed by Dr. Ashid in the previous slides.
Okay, Assalamu alaikum. Kumar, my name is Khalid. I am a resident, a doctor working here. So you are 28 years old and coming here today with a history of chest pain. Is that right? I'm going to go through some questions with you. Can you tell me something more about this chest pain, please?
Actually, I felt like more than tightness, and I became like shortness of breath, and I couldn't take any deep breath.
Right, okay. How long that lasted for?
Well, it was around 30 minutes.
Right. What do you think was the character of the pain? Was it a tearing, heaviness, or?
I felt like something compression on my chest, so I will go
heaviness. What do you think pain has been made worse by? Like changing position or exercise or?
Well, with movement, so yeah, maybe with exercise.
Right. And what about sweating? Was there any associated sweating?
Well, I didn't remember well, but I think I sweat a lot.
Oh, right. What about radiation of pain? Was it just heaviness in the chest, or coming to your shoulder or neck, or?
Well, first started here, and then maybe it went toward my left hand. Yeah, I felt something.
Right. And how severe was it? We've got a scale we use from 1 till 10. 1 has no pain, and 10 has the more severe pain. Where would you place your pain score?
Well, I would place it on 8.
So it was quite bad, is it?
Yeah, it was.
And what about the onset? Was it sudden or gradual onset?
Well, it started with me when I tried trying to lift my little child, and suddenly I felt uncomfortable around my chest, and then I felt like tightness. But then,
and when was that?
Well, it was maybe like 6 months back, but then became more and more severe. And now.
Okay, let's some of the routine question now. Are you diabetic?
Well, no. I don't.
Do you take any blood pressure medications?
No.
Or medication for high cholesterol?
No.
Right. And do you take any medications at all regularly?
No, actually, I'm not taking any medication.
Okay. And some other routine question now. Do you drink alcohol? Any recreational drugs that you use?
Absolutely.
Right. Anything significant in the family?
Well, my father suffered before of acute myocardial infarction, and actually this is why he passed away.
Right, right.
So this is why I'm worried about my condition.
Okay. So one final question now. Any other symptoms like high temperature,
No.
coughing,
No.
heartburn? Okay. So what we'll do some examination now, then we'll discuss with you the findings, the possible causes, and the solution. Is that okay? Excellent.
So just go back to the Ashid's slide, what we talked about. Non-verbal communication skills, verbal communication skills. Okay, let's focus on these topics and see what you guys think about this. What non-communication, it's a non-verbal skills that he has demonstrated.
Non-verbal communication was such a thing in patients.
Yes, yeah.
Yeah, so he was sitting in the patient's level.
Any other comments? Now sitting at the high level, okay, and talking to the patient. Any other comments? What other non-verbal communication skills is there also? There's quite a lot. Okay, I will just give some clues. Okay,
He was showing concern to the patient's complaint and he was listening actively.
okay, active listening, okay, very good. So he said the word active listening. What does it mean?
So he's giving him his complete attention. He's not looking at mobile or busy with his papers or looking around or ignoring him in any other way. Okay, so he's being focused with what he's saying.
Okay. So that's one thing. Anything else? Active listening.
No interruption while the patient was speaking or explaining.
Okay. So you said that no interruption. Okay. How many of you think that you follow the patient? One of the terms is following skills. Okay. How many of you think that he had a good following skills? That means allowing the patient to talk and explain in their own words, their own ideas, their own concerns. How many of you observed that happened?
I feel that in between he was cutting the patient and asking for the history. So it was like he was not giving enough time for the patient to tell his concerns completely. He was in between, like cutting him and asking him further. Okay, we'll go to the next question.
Yes, yeah. So when you look at any clinical consultation, okay, what is this consultation? There are certain tasks and skills we have to do. Okay, that's part of your clinical consultation. Okay, so in emergency department, we don't have the luxury of outpatient clinics at that. We have to do focus history taking in a timely fashion and get to the bottom of it. What is the problem? Give it a chance. Okay. So during this consultation, what are we doing? We are trying to address the patient's agenda, and you also got an agenda for yourself. You want to get to the answer for what is his problem, the disease specific diagnosis and the management plan. From the patient point of view, he or she would like to address their illness related problem. Okay, they may want to say my ideas is okay, or my concerns is okay, what is my expectation. So both these need to be matched. Okay, and then finally we come to a, what did Dr. Ashid put? Shared decision making. Okay, shared decision making, and then agree on the what is going to happen next. Okay, we may have to be on the, hopefully you've seen from the slide, patient centered care is not about what all the time patient wants. Okay, it's about be realistic. It's what is necessary now. Okay, what is achievable in the time patient. Part of the consultation is about explaining in detail what should happen next. What is the time frame? For example, in the last 1 minute of the slide, Dr. Khalid mentioned, what did he say? He said that I'm going to do some examination, I'm going to do some investigations, advice on investigations. Okay, we will discuss what are micromanagement plan. Is acceptable? Is a sensible plan? Yes. Okay. How else this could be? Do you see any problem in this? Put this picture patient in emergency entry. Okay. After the initial presentation, after discussion, he goes and sits in the room. 13, 14, 10, corridor. Okay. So what's going to happen? Timeline. Okay. So he doesn't know. She doesn't know what's going to happen with them. How long? They have to wait. Okay, so giving some time frame will be useful. Okay, so that the patient knows what is going to happen. Okay, how long is going to take, so the patient is fully informed. So there's some understanding thereby when using the conflicts, misunderstanding, and the arguments and stress. Okay. With regard to the what was I mentioned about active listening? What other things meant by active listening? So interesting. So Geoff is completely focused on the patient. So how did he introduce? It was introduction good.
He was smiling
and then introduce himself by name and then grade, okay, and what position, okay, and he also identified, so it come. Only other point he could improve will be is the right patient, okay. So what else? The introduction to the doctor is good. So what else? How did he start it? How did he start the medical consultation, gathering the information? Did he start with open-ended question? Given a chance, it could be asking, then we should ask him, open the question, how can I help you? Okay, what has brought you here to the hospital today? But how did Dr. Khalid start it?
He pointed out that he complained of chest pain and then he asked directly about the chest pain.
Okay, see, in a way, he started straight to the point. Okay, that is, you come here with chest pain, and then anyway started with the closed technique. Okay, sometimes if you do this, you may be focusing on your agenda. You want to get to the history and the what was the problem. It may not address the patient's agenda. Once you start with the patient's agenda, then with open question, we can then explore more. Okay, did he explore? Did he explore the patient's concern or the patient's problems? Yes? Yes, he did. He asked many probing questions. Tell me about this, okay? Or what was the style of probing questions? Were they open or are they also closed? They are more or less, most of them are closed question, leading question, okay? That the way Dr. Khalid wanted to address and take the box. What else he was doing? What else he was doing while taking history? What else he was doing?
He was checking the list.
Check sheet, okay? So sometimes, okay, what do you think about that? He is ticking the box, okay? What do you think about that? Okay, maybe that's one point. He may be, though he doesn't want to miss anything, okay? It may be good at a very junior level point of view to use the checklist to but do you think it will address the patient's agenda? It may address your agenda that I want to finish 8 points in the history, but do you think it will address the patient's agenda?
It's easy to miss things.
Okay, easy to miss the things, okay?
Then you need, like, to gain on certain things that the patient is going to do.
Okay. Sometimes it's useful to keep a checklist, but obviously focusing only on checklist may not be really patient-centered communication. Okay. What about reflective? So part of the active listening, Dr. Ahmed was mentioned, is about three things. One is non-verbal communication. Second thing is about following skills. And third one is about reflective skills. Okay. When I say reflective skills, what do I mean by that? Again?
Summarizing what you
Summarizing one, yeah. So just going back to Dr. Ashid's slides, okay. What did Dr. Ashid mention? Paraphrasing, okay. Echoing the patient's emotions and the feelings in the correct context, okay. Restating the patient's problems, okay. Did he do that? Did he acknowledge many of the patient's symptoms? Yes? No? He did many occasions. What did he say? When he said, oh, I got the pain score 8 out of 10 for 30 minutes, what did he say? Yeah, he's acknowledging that he's okay, making normalizing, okay, I understand that pain, okay, he's echoing that, okay, that making sure the patient is feeling that, okay, I heard you saying that your pain score is severe, okay, so that's a very good skill, okay. So if any other, in the context of active listening, with regard to following skills, what he could change or what you could like to change? How can we improve the conversation? There are two occasions specifically in this video where what happened. When we talked about 6 months ago, I had this chest pain. Okay, what happened afterwards? The patient said. The conversation was ended there, and then the resident started saying that, okay, I want to ask some general questions, okay? No exploration of this, okay? No concern, the patient's concern was not necessarily addressed. Similarly, around 3.5 minutes, what happened? He talked about my father died of myocardial infarction, and that is why I'm really worried, okay? So what, in an ideal situation, what should have happened? Okay, you should have probably explore more, a little bit acknowledge that somebody died, okay, and emotions, yeah, sharing the emotions, a little bit more empathetic on that aspect, okay, so that will be much more useful, okay. So talking about empathy, what do you think? How easy, how difficult it is? How difficult, how easy it is for us? Yes, okay, yes. The part of empathy is about how you have your own feelings, okay? What do you value? What is your own belief? Okay? What you think about yourself? It's something called self-awareness. Okay? If you know about your strengths and weakness, what's your belief, values, okay? That will be really useful in managing the empathy, okay? On that one aspect, but otherwise, how did the resident dealt with that patient? Overall, was he empathetic to the patient?
Yes.
Okay, good. Yeah, he was on other side, other areas, he was very empathetic to the patient. He was acknowledging quite a lot. He's reflecting on, he's echoing back on the key things the patient mentioned. Okay, what other communications, non-verbal communication things you observed? Just trying to finish this. What other non-verbal communication things you observed? Sitting at eye level, what else? Talk.
Voice.
Yeah, very good. Voice projection. Okay, whenever it's needed, voice tone has gone up and gone down. Okay, and what else? What about his facial expression?
Blank.
Is it? He says she thinks it's blank. How many of you noticed that the resident's facial expression changed when he was acknowledging things? Yes, his facial expression changed. Okay. What else? Body posture. Okay. Okay. Very open posture. What about hand movement, other gestures?
He's nodding.
He's Yes, yeah, okay. Good, appropriate eye contact, okay. Nodding things, his hand movements are moving around. And what about clarity of speech? Very clear, okay. He explained about, for example, one good example will be pain score explanation, okay. It's nicely explained to the patient in an understandable way, okay. And then when patient said, my pain score is 8, he acknowledged it, saying that, oh, that's been very bad for you, okay. Okay, right. So I know it's very time restricted discussion. So in summary, what have you guys observed in this history and consultation? So in summary, basically is managing your agenda with the patient's agenda. Okay, always start with establishing good rapport. Okay, and start with open question. Try to explore. Of course, sometimes if you're not able to get where you want to go, then you can start ask leading questions, okay, and probing questions and get to the bottom of it. Again, it's important you share the mental model, okay, what's your decision-making process, and share with the patient and summarize. Make sure the patient understands the summary of this, and most importantly, what is going to happen next with the time frame. Okay, I'll stop with that. Thank you.
Okay, thank you. As you know, actually this video was aimed at demonstrating rather than action. But I really struggled to make it tone it down. In fact, we shot this video a couple of times to make sure we actually cuts in and stops the patient from talking and giving a detailed history of something. And the script had to be followed a little bit differently from what Dr. Khalid is naturally very good at doing. You've all observed him in practice. So I think what we were trying to get across there was, although nodding your head and accepting, acknowledging is something that we think is enough, when you watch it, it doesn't feel right. There's something missing. He was more intent on ticking the boxes and getting the information rather than trying to make connection with the patient. That was 5 minutes, and that's all you're going to get in ED practice. And don't take us wrong, if this patient had an ST elevation MI, you're not going to explore the patient's agenda in a lot of detail, are you? I mean, you're going to go straight in, ask a whole lot of close questions, and determine his suitability for PCR and get him escalated to the right place. On the other hand, the patient comes in with slightly vague symptoms, and you want to understand exactly why they're here, then you would probably want to spend a bit more time exploring them. So we will be applying these principles flexibly, depending on the patient's scenario. So a lot of the messages that you came up with and was discussed are quite important. I think that's the reason we use this scenario. Some of you might have watched them before for other purposes, for example, chest pain history taking, or for the purpose of communication as well. So we want to move to the next scenario, which Dr. Khalid is going to lead on de-escalation negotiations. Thank you, Khalid.
Okay, so now moved on to de-escalation and negotiation in patients management. Can you all hear me? How about now? Better? Okay. So my talk is similar, based on the theme we have seen, and we'll show you some video. We'll ask for your comments, and then I'll give you my feedback and summary with some examples that we as ER physician can learn in terms of administering management, treatment. So that's the history. Same, you're familiar now that the patient wants to go home. He has got chest pain, he has been waiting too long, so he has to go home. And the physician who is working, so I'll let you watch video and then think about, on the background, we are working to convince the patient to have the treatment or the management and what skills as ER physicians we can utilize to help him. Okay, now different actors this time.
Assalamu alaikum.
Alaikum salam.
Mr. Hamza.
Yes.
I'm Dr. Amr, emergency consultant.
Yes, Dr.
I have been informed that you are upset. Sorry for that.
Yeah.
What happened?
Yeah, I'm here waiting, and I don't know what I'm waiting for. More than 3 hours.
I'm sorry. Can I have a seat, please? Have a seat, please.
Thank you.
Okay, Hamza. Mr. Hamza, I have been informed and I reviewed your notes that you are waiting here for around 3 hours, that you developed some chest pain 6 hours ago, but you are fine now. And the doctor who examined you ordered some blood tests to make sure that everything is okay.
Yes.
Yes, is that okay?
But I'm waiting more than 3 hours for this, and I cannot wait anymore. It's too much time. I can leave.
I'm sorry for that. I appreciate your patience that you stayed all this time. Mr. Hamza, I want to tell you what we are waiting for. We are waiting for a blood test to make sure that you don't have any serious problem in your heart. This blood test called troponin, which is, if it's elevated in the blood, means serious problem. I hope it will be fine, but we want to wait for that.
Thank you for your concern, doctor, but I cannot wait anymore. I need to leave, please. I cannot wait. I didn't get water since 3 hours. There is no water here. Even when I'm asking anyone to go out, they told me just wait, we will call you. And I mean, more than 3 hours, nobody called. And I'm waiting here, no food. My wife and my son, they're waiting me. And
I'm sorry
I cannot do anything for them.
I'm so sorry for that. I can understand your concern, all concern. I will try my best to try to solve this concern. For food and water, I will arrange for you a meal now. Sorry for that. I will call also the laboratory now to make sure that the blood result, the time of the release of the blood result, and I will come after 10 minutes to inform you. Sorry for waiting all this time, but I'm sorry for that. But you know that we are caring for you, for that we don't know exactly what we have now. We want to make sure that you are safe, that we should wait for this blood test to make sure that you don't have a serious disease which can affect your life.
Too much.
I hope no, but it can.
Nobody tell me that I will wait that much of time.
I really sorry for that. We should wait for the blood test to make sure that you are okay. Don't develop any serious disease after that. I hope that that the result will come okay. And as you know, that you, as I reviewed your notes, and I realized that you don't have any background of any disease, serious disease.
But I cannot wait. I cannot wait. I need to go. I cannot wait. I need to go.
Sorry for that.
My mobile chargers.
Yeah.
It's running out.
Yeah, no charge.
No charge.
Also, I think I can help you with that. Also, I will try to search for you any charge for that.
Thank you.
But my concern is that we want to wait for the blood test to make sure that you don't have any serious disease. Okay.
What is the serious problem for me?
Okay, our concern is that about if you develop any heart attack. Do you know heart attack?
Yeah.
That something serious can affect your future work or capability to work. So we want to make sure that you don't have this serious heart attack. Okay. The blood test you are waiting is called troponin, which is heart enzymes, which can be elevated if you develop any heart attack. But we hope that it will come negative, which is normal. That at that time we will inform you what's the next step. How can we refer you and arrange for another appointment in outpatient clinic? Okay. Sorry for waiting all this time, but this is all for your care.
Okay. Thank you. Thank you, Dr. Ahmad. Thank you very much, Saleem.
Thank you, Mr. Hamza, for understanding.
Thank you.
Okay. Thank you.
It's an acting, but we do come across this in real life, isn't it? So we'll have a discussion. I've got about 14 minutes. I'd like you to tell me, what did you think about what skills this emergency physician utilized to de-escalate the situation, and what could be improved. Okay, be specific. You can't comment that he's a bit muscly, or he's a bit short or tall, or handsome, or so be specific. What is the skill that you have seen, and is it good to practice? Maybe use the mic so everybody can listen to you. So raise the hand and use the mic, please. Okay, but just
we apologize very well. It's a good thing. We'll go on for next thing we did is we assured the patient that his concern would be addressed. And we went on and addressed the concern. And as the patient was getting a bit angry or aggressive, he did not reciprocate. He kept it on. And he kept his cool. He just did not show any aggression for us. That's good.
okay, excellent. Lot of points. Give somebody else a chance. So you see, acknowledgement, empathy, sympathy, and he had a listening ear and apologize. He said about 5-6 times, "I'm sorry for this, sorry for this." So these are very good key points. 4 or 5 mentioned. Anything else that?
I will just discuss with the staff the sitting limit and the volume of book for private places.
Okay, a good point. Privacy.
Can frustrate his anxiety and concern easily. This is not other patients that could
Because the time is limited, just mention the key points. So privacy is important. And anything else that you have noted, or would you like to recommend any change for the next video short? Okay.
First of all, if we go back to the previous lectures, there's a mistake that happening here that the patient didn't even know what he was waiting for. From the earlier lecture, we understand that the patient should be informed about what the investigation and why he's waiting for this investigation.
The key skill that physician used is apologized and explained. But the problem was, yes, it was a lack of communication in making aware about the waiting time. Any other key skill that he should have used? Okay, so we got 10.
Something positive. One of the things I noticed with Rahul was showing his hands all the time. He's actually supposed to be constant. So if you want to hide something, you have a way with this. And this is based on certain evidence that outside medicine, but there's a amount of evidence that suggests if you throw somebody your hands, they are more trustworthy automatically. I was doing that all the time. I was quite impressed by it. Because I'm not good at this kind of thing. Most people can probably come and we're doing a demonstration which I would like to think.
I will discuss in the next 9 minutes, reinforce the key qualities for de-escalation, and then I'll share with you some examples. I think we'll learn better with examples. I have been in this trade in emergency for so long, I can share with you example about clinical, non-clinical. In UK, in my job in Wales, I used to do a grand round on claims and complaints twice a year. And it used to be loved by physicians in the hospital, and used to be a packed hall, because we learn from examples, we learn from mistakes. Okay, so coming to the video, I think you highlighted the key skills. You need to be sympathetic, empathetic, listening to the patient, and apologetic. When you apologize, it doesn't mean that you're apologizing for the mistakes. You're apologizing for the delay. And sometimes you start conversation with the apology, and patient do calm down. When you say, I'm very sorry that this has happened. In our real life, things changes almost 180 degrees. Not always, but it does start with the conversations. So what Amar could have improved, towards the end of the video, he said, thank you, Tropony. He could have summarized, look, we have discussed 5 minutes now. You are going to wait for the results. Is that okay? And I'm going to speak to pathology lab to get the results, get the timing for the results. And I'll get a mobile phone charger for you. I'll get some food for you. Although he may have mentioned during the conversation, but because he was anxious, angry, so he might not remember. So his key areas were, what were the key concerns that he had? One was the food. Second? So waiting time, phone charger, and his family waiting. So these were the hidden things which was making him angry. And remember, patients come with a hidden agenda. Sometimes the waiting, he's angry because the blood test is not ready. But when Amar explored and explained the importance of blood test, food, drink, and he calmed down. In reality, it does happen. Not always, but if you address the hidden agenda, patient do calm down. So summarize is quite important, particularly in the heated discussion. At the end, you summarize. That also reminds a physician to do things, and also for the patient to wait and think about. So summary was the important that Amar could have done. Otherwise, when we made the video, we made 2 videos. One was that the nurse comes in, doctor, can you do Dharma form for this patient? And the physician goes to the patient. He says, okay, you don't want to wait. Are you sure about that? You understand the risks? He said, I understand. So he signs the Dharma form and leaves the hospital. The second video that Amar did was actually exploring hidden agenda. What is the reason that he come in? And you will, I think Ashid highlighted in the beginning that most claims and complaints happen due to communication errors. You might have understood the term underperforming doctors. Do you know about it? And do you think what is the commonest reason these doctors are labeled as underperforming doctors? It's not the lack of medical knowledge. This is to some extent, but it is the professionalism. It is the communication problem. That's why Saleem and Professor Stephen has dedicated the whole day towards this workshop, so you can take home maybe 2-3 key messages and that you can use in your practice for your own benefit and for the patient's benefit. So I'll share with you 2-3 examples, and then my personal examples, one here and one in UK. My third baby daughter, she is nearly 18 now. I took her to the dermatology clinic, and so I went with her. And I didn't tell that I'm a physician working. So there was a dermatologist and 2 of his associates came to the room. And they walked in and he said, we know why you're here. So he started explaining, this is acne, this is comedone. Okay, we'll give you a cream. And he just went back to the room and wrote a prescription. And my daughter was furious. She's almost height as I am. And she said she's not having his treatment. She's not coming back. So I took her to a private clinic. So there were so many problems in this consultation, no introduction at all, and no introduction of the team. And the outcome, not as a patient, but I can sympathize with my daughter, that she never wanted to see him again. And so she didn't go back again. So you can imagine you as a patient in emergency department, when we don't speak the language, we don't know about their cultures. I'll mention a few things about culture. So it's very important to be a skillful physician. You need good communication, and that will save patient hassle and us long-term hassle. Okay, the second example, as you know, my interest in vertigo, I think that could only happen by practicing in UK. If I had practiced in Qatar, I would have stopped on my first year. So what has happened here when I do the vertigo maneuver, a lot of time, halfway through I've been stopped and patient says, oh no, doctor, I'm going to die. And the patient says, doctor, what are you doing with my dad or mom? In UK, I explain to the patient and patient comes in by ambulance, as they're having stroke. And they walk in with the ambulance guys and I explain to them, look, this is the problem, I can fix it. And they go home unaided, the color changes. So that gave me confidence. But here, culturally, I don't know, people can't take the pain or there is something different. So we need to be mindful of the local culture. So one of the skills you can use is utilize the family members in convincing the patient. Obviously, you take the consent of the patient. And some things are in particular culture that you need to understand. So you need to be, for example, Ashid mentioned, I was also told about EGY syndrome. I thought this patient is having MI, but one of these clever Egyptian specialists told me, no, he's having EGY syndrome. So you need to be sensitive towards the local culture. Because why? Because it will help you to approach patient appropriately rather than doing unnecessary investigations. So utilizing the family member is a useful thing. So I'll summarize the last couple of minutes about what skills we should use. So one is you need to be sympathetic to the patient, In the last video we made with Hamza, it was an interesting point generated. He was talking to the patient in our workshop and the doctor was saying, great. Hamza said, I've got a chest pain, I want to go home. He said, great. And great 4 or 5 times, which we normally say. And at the end, he said, why are you saying great? I'm having chest pain and you are saying great. So, the words we use, the tone we have, remember you as a patient, if I'm telling my daughter's example, and he might be a good dermatologist, that's why he's a consultant there. But she said she's never going to see him again. And so just put yourself in the patient's shoes. How would you like to be questioned? And how would you like to be answered? It takes a bit more time. If we follow the nursery request pathway, sign Dama, that's it, one less patient. But he might come back again with MI next day. So remember, we all need to be sympathetic, empathetic, and honest. And use the family members in a treatment which you believe as a physician is good for the patient. Is that clear so far? It's a very short time, but if you can take home one message, that we all need to be sympathetic, empathetic, and listen. Because sometimes there might be hidden agenda that you can only explore by listening. If you listen to Amr, mobile phone came towards the end in the consultation, isn't it? Maybe this was he couldn't talk to his family. And I'll finish my talk with not a joke, but it's a real story. And you can only explore by listening. So a patient I saw, not here in UK, the presenting complaint was back pain. So I took the history, all the red flag symptoms, and I said, okay, I'll give you some analgesia. He said, when he trusted my communication skills, he said, by the way, I fell at home on a perfume bottle and it got in my back passage. So if he was rushing, he would have never told me that the problem is foreign body in his back passage. So I think be patient, and they will tell you things that they will never tell anybody else. Okay, thank you. That's the end of my talk.
I'm going to be a lovely medical registrar, and Dr. Ayman is going to be my victim. Oh, sorry, I've been an emergency doctor. Okay? And this is hopefully an example of trying to endorse a patient to another specialty as realistic as possible. Okay? Right, so we're on the phone, so that's why we're our backs into each other. Alright? So, yes, hello, this is the medical registrar. Yeah, I've had 3 leaks already from this number. Is it 3 different consultations or just 1?
Hello, good afternoon.
Yes, hello, this is the medical registrar.
Hi. Can I know your name, please?
Yes, it's Dr. Alison.
Hi, nice to meet you. So, I have one issue here, not very clear. I know our case and our supporters way, but I don't listen to our problem patient now.
Yeah, can you just give me the HC number, please? I've got loads of patients, I'm very busy. Just give me the HC number.
HC 3024.
Okay, yeah, you've spoken to me about this patient already today.
Yeah, I know. But I didn't speak to you about it. I'm taking care of him now in our group. So she's a patient with history of back pain, and she previously has a history of breast cancer. And I would share it because we find like lesion in the spine, that's quite straight. And we want to see her.
Yeah, she's going to have an MRI, that's the plan, isn't it? Neurosurgery, we've seen her, she's going to have an MRI. That's the plan on Cerner. That's my understanding. I don't know why you're ringing me.
Yeah, because this patient already, we found her with this new lytic lesion, which is new for her. And she was free from cancer for 2 years now.
Yeah, but she might have a neurosurgical problem. She's got sensory loss in her legs. She's been seen by neurosurgery. As far as I'm aware, her plan is to do an MRI to make sure she doesn't have other lesions, as well as the one that you can see on the X-ray. So, like I said, I don't know why you're ringing me.
Yeah, we plan to do MRI, but the patient, she has claustrophobia, cannot do the MRI now. And the MRI need to be planned later. And honestly, I think it can be done later, and I don't think neurosurgery will do any urgent intervention for her at the moment.
So, you don't know that though, because the plan is that she has an MRI.
Yeah,
and she might have some neurosurgical problem that we don't know yet because she hasn't had the MRI. And like I said, she's quite well. I don't really see why she should come to a medical bed when the plan clearly is that she sees the neurosurgical doctor. So until she's had the MRI and has a result that clears her from neurosurgery, she's not a medical patient, she's not coming to a medical bed. And my consultant's aware of this patient and she needs an MRI.
Yeah, we can do MRI at the moment, that's the first thing. And I spoke with oncology on call, and he informed me that we need to admit her under medical for continuing of her care.
So just because oncology say admit her, she has to come into a medical bed when she's absolutely fine. She's really well, she's got normal vitals, she's got one issue which appears to be neurosurgical, and there's a plan for her to have an MRI. Just because she can't have the MRI doesn't mean that she changes her plan and just comes in under medical and takes up a medical bed. I don't know why she can't just go home and have the MRI as an outpatient in that case.
I don't know if she can go home at the moment because she's having new lesion which she need to be investigated.
Exactly, so she needs to see the neurosurgeon after MRI. So why are you ringing me? Pointless, you're just wasting my time. Like I said, I'm really busy, I've got a lot of patients, you're just wasting my time. I don't even know why we're having this conversation.
Yeah, I really appreciate that you are tired today and you have a busy shift. But I believe this patient is primarily a medical case. And
she's not a medical case, she's, until proven otherwise, a neurosurgical case, because she has a lytic lesion on X-ray in her back, which is probably metastasis, and she needs an MRI. I'm not accepting the patient, she needs an MRI.
So if MRI is done, so thank you, and we'll discuss with my consultant and we'll discuss later with you.
Okay, fine, thank you.
Thank you.
Okay, send this now. One of the reasons that I can't look at Dr. Ayman is because I'll either laugh or just crumble with guilt. So first of all, has anyone... Yeah, we all have, haven't we? And I actually, obviously, I was trying to be mean, but I think that's a fairly accurate representation of what happens, isn't it? So first of all, how does that make us feel? What does it? What emotions do you feel when you've got that scenario? When you're in that position on the telephone? Yeah, frustration, hopeless, yeah. Angry, I would say embarrassed, makes me feel embarrassed. I'm a consultant trying to refer someone and then someone junior to me is resisting. But yeah, you feel wronged, yeah. So it makes you feel uncomfortable, so immediately you're on the back foot, aren't you? And you just feel disempowered to some extent. And then also maybe for those of us who are less senior, it can make you feel insecure about your own sort of abilities and then makes you uncertain. So what could Dr. Ayman have done in that situation, do you think? What strategy could he have, from Ayman's side, what strategy could Dr. Ayman have used in that situation to try to get somewhere in that conversation?
He could be more confident about his presentation, and for example, he could say, I have straightforward admission for you as planned from the oncology team.
But then he could
manipulate for chemotherapy or for therapy to start, otherwise it will further damage the spine. She may become paralyzed or something.
Yeah, good point. But do we always do what the specialties advise us to do is one issue here. So just because oncology have said admit the patient, is that a good strategy? Do we always do what specialties tell us to do?
Well, the thing is, because we are working up this patient and we will not consult any subspecialty unless we need something from them. So if they came up with a plan, so then we need to follow it.
Maybe we could get oncology to speak to medicine directly instead of using us as the secretary in between, maybe. So anyway, so that's one point, that we are following a plan for the patient and we're trying to honour that plan. Yeah. Yeah, okay.
You should have not listened to. You should have listened to what you should have still said that I am the one who takes care of the patient, I think that is what he needs.
Yeah.
And you might have everything, but as the physician taking care of the patient, this is his best interest, and that's that.
Yeah, so the point there was that Dr. Ayman could have been more assertive, but do we think that the medical doctor, even though she's being quite rude and abrupt, do we think she's got a point? Yeah.
She actually has a point. It doesn't mean that she's working with it.
Yeah.
So in case that the referring physician feels confident about his approach, he can just thank her and he can escalate to the consultant on call.
Yeah. So your point is that a good strategy in that situation where you're in an impasse where there's no one's going anywhere is to then escalate to your own consultant. Because, I might, even as the consultant, discuss with another consultant in that situation because I'm frustrated, embarrassed, angry, I've got nowhere. And so I then need to discuss with a colleague, even if it's just to decompress my own feelings. This is reality. Sometimes it's not easy even for the consultants. We're all in this together. So I would say escalate and share the pain, share the issue. And sometimes you are so embedded in the situation that you can't see the wood for the trees, we say there's an English saying, but you're so embedded in the detail of the situation that you lose perspective, and then you're so overcome with the emotion of the situation that you can't think objectively. And so it helps just sometimes just to speak to a colleague. So you could just share it with a colleague, and obviously we're busy, but I would escalate. What about Dr. Ayman's use of S-bar? Was that good? Yeah, I think it was. Dr. Hayder, what do you want to say?
I don't think we are on the same page. I know someone has got Geoff from the UK. That's one point. That's the objective of S-bar.
Yeah. Yes, Dr. Hereiz says, thank you, that, you could sort of appeal to the humanity of the other doctor and say, look, this is a patient we both know. There's some more information. Oncology want to admit her now, regardless of an MRI result. And actually, as it turns out, she's very claustrophobic. Maybe she's had MRIs before, and this is an issue. It's going to take time, isn't it? We're going to have to get an anaesthetist probably and do it safely. But does it really change her management if oncology thinks she should come in? So we can negotiate as well. So we can use ESPAR, of course, which is what we should try to do. What about Dr. Ayman's mood, though? His tone, the way he spoke to the doctor. Yeah, very calm, wasn't he? Maybe, but that was because I was purposely being aggressive. Sorry, too much breath. That's because I was being aggressive on purpose. So he was maybe on the back foot in terms of, just being able to get his point across. But he didn't lose his temper and he didn't rise to the provocation either. And although obviously it's a scenario, he was far away from actually engaging in confrontation. So that's another kind of learning point maybe from this scenario, that we should try to avoid confrontation. So even if we feel those emotions, even if we feel angry, better to just close the conversation than to engage in an argument or into a fight, which then, ultimately we would lose anyway. Because we're not getting anywhere in this scenario, are we? We need another solution. Has anyone got any other comments or questions? Yeah.
Also, it could show some sympathy with the registrar and address the problem. I know you are busy and you have so many of patients, but you can maybe endorse the other registrar, or you can see him after one time, because it's not that urgent. I mean, you can identify whether it is urgent or not urgent.
Yeah. So again, appealing to the humanity of the doctor, maybe. Yeah. Yeah, that's right. So that's another good point. So negotiation, and we've heard about negotiation already this morning, but negotiating, saying, is there something that I can do that will sort of help out in this situation? What can I do to make this, to get a conclusion to this problem? And so that's always a good thing, to sort of acknowledge the busyness, but then to say, okay, look, if we maybe in this scenario could say, look, okay, I will try to get the MRI, but we both know that the patient is going to be a medical patient, whether it's now or in 5 hours' time. And so therefore, for the patient's sake, let's have a plan for admission, but let's also, I will try to organise the MRI so that wherever the patient is, whether she's still in the emergency department or she's happens to go to a medical bed, the arrangement for the MRI is made. And so that kind of helps out the medical doctor, because she might be thinking, do you know what, I am so busy, I'm so stressed, and now I've got to organise an MRI with an anaesthetic doctor, and I'm just so busy. So you don't know what's going through her mind. And I think that's another thing to say. You don't know, none of us know where people are at in terms of what's going on personally with each other, with colleagues. And maybe she's struggling with a sick child at home, or an unwell parent, or she's got a housing issue, or whatever it is. She may have some personal things going on that are affecting her performance at work, and that's not an excuse, but it could be a reason. So I think all of us have to be, just as we don't judge our patients, we have to just be kind to each other. So what Dr. Ashid said about being nice, start off with kindness first, and always maybe have that as your kind of hallmark regardless. And bear in mind that we're all human beings trying to do our best for the patients usually. Yeah. Okay, so yeah, Dr. Shukla. Sorry about the breathy microphone. I'm holding it too close or not enough.
More like comments rather than questions, but when patients like this with complex problems present to the emergency department, sometimes it's way outside our scope of understanding in terms of pathophysiology and therapy. And I think if we ourselves obtain an understanding of that in more precision from, in this case, from oncology and neurosurgery, it would provide us with more, so to say, ammunition to discuss with internal medicine. For example, this patient already has had a CT scan. CT scan does not very accurately tell you about whether there are more lesions inside the spinal cord or not. But it is very accurate in telling us whether there is more compression on it. And that question is probably being answered if the CT scan has been done. So a quick discussion with neurosurgery about, is this MRI going to impact on a neurosurgical decision making in an emergent sense or not? And a discussion with oncology about why do you want this patient to be admitted? Can't you see her in your daycare center after the MRI is done? We may just be able to avoid an admission, which may be of value. Finally, writing an admit order or getting an admit order written by X specialty is in itself not a therapeutic intervention. By itself, it doesn't improve patient outcomes. So, as Alison said, there's not missing the woods for the trees. Sometimes you get so focused on getting a dispo on the patient. The dispo is not by itself a therapeutic intervention. That's all I have to say.
Thank you. So, I think we'll conclude there and pass back over to Dr. Saleem.
This was a video that was properly scripted, but it's not, so it could all go horribly wrong. It's not intended to be perfect. We're looking specifically at the communication aspects of what we're doing, which is a resuscitation. I would like one more helper, if possible. Could I borrow a resident from somewhere? You won't get, thank you very much, fantastic. Okay. So the scenario is this: a 50-year-old man has been brought into the emergency department in PEA arrest. History is that from the EMS they've had diarrhea and vomiting for 3 days, had minimal oral intake, no past medical history is available because there's a maid and that's all, she doesn't know anything. And on arrival, CPR is ongoing. So Ayman, can you come and do chest compression? Sif, can you take over the airway and manage the airway? Resident, I'll use you as a standby if you don't mind, and if you can do circulation and give drugs and put fluids in, and I'll try and keep the time as we're going on. Okay, so if you, right, Ayman, can you do a bit faster? That's not really fast enough, and can you do more effective chest compressions than that? Can you, how is the airway? Can you manage the airway? So, right, could you listen to the chest? And I'd like you to just to sort of do all the things that you would normally do in a resuscitation. So you're managing the airway completely. You're doing chest compressions. So you've got a cannula. It's a small cannula in there. Can we get another bigger cannula? Oh, we've got another bigger one there. We need to give some fluids. They've given 200 mils of fluid so far. That's really not enough. So what we're doing at the moment is doing CPR effectively in cycles of 2 minutes, and every 2 minutes we're going to reassess the rhythm. We actually haven't assessed the rhythm while we've arrived, so can we just stop briefly? Okay, and we're looking at the monitor. It looks like PA. Is there a pulse? There is no pulse. Thank you very much. Carry on chest compressions. I'm sorry, we haven't got a Lucas, so you're going to have to keep doing it. Okay, so that's 2 minutes from now. All right. We don't know when the last adrenaline was given by the ambulance, so we'll give one next cycle. So if you can get adrenaline ready, could you take some bloods for venous blood gas and other things? But as soon as you get a venous blood gas, if you can bring it back to me. Okay. And team, we need to look for reversible causes to try to find why this patient has gone in PA arrest.
I'm feeling tired now.
Right, can you take over, resident, if you don't mind? It seems likely that hypovolemia is the major cause, but listening to the chest, Was there any, there's good air entry, no sign of a pneumothorax, retention pneumothorax? Right, okay. So we're going to, the history doesn't really fit with hypothermia, but we could measure the temperature. Hypovolemia, hypoxia, well, we're trying to manage the hypoxia. Have you got oxygen going in that? Yeah, can you make sure that there's oxygen going in, that we're not hypoxic? And as soon as you get the blood gas back, can you tell me the results? I suppose at some stage we should think of things like thromboembolic. Again, the history doesn't really fit with that, and a tamponade. Ayman, can you try and get hold of an ultrasound machine and then get it ready so that in between the sort of, when we stop chest compressions, you can have a quick look to see whether there's a tamponade and maybe there's a very dilated RV, okay? Right, it's 2 minutes. Can we stop? Can we do a chest pulse check? And no pulse, thank you. And on the monitor it looks at PAA. Carry on please. Right, can we give adrenaline, please? Okay. Thank you very much. Okay, any other thoughts, team? What we need to, how much fluid have we had so far? Really? I think we've probably only managed the first litre. So if that one's in, can we give another one, please? Because I suspect we've... okay. And I tell you, can we get a pressure bag to put that in rapidly? Okay.
Ultrasound is ready.
Fine. So next time we stop, could you actually get the probe ready? If you may have to come around the other side, get the probe ready so that, because it's quite difficult to find, but see if you can sort of get roughly in the right position so that we can see whether there's a tamponade, or see what you can find now where we're going. But we've still got another minute before our next 2 minute stop is. Okay? Still happy with the breathing?
Yes.
It's going in easily enough, so there's no sign. All right, how's that blood gas going?
Still waiting the result.
Still waiting the result. Okay, thank you very much. Any other thoughts, team, as to what we need? Sorry?
RBS check we have?
Sorry?
Do you have RBS check?
RBS, you mean?
Blood sugar.
Blood sugar.
Yeah. We'll get that from the blood gas, won't we? If you can do that. All right. Okay. Start getting your probe ready, Ayman. We're going to stop in a minute and have another pulse check. Okay. Okay, it's now 2 minutes again. Stop. Do a ultrasound and a chest and a PA. We've still got PA on the monitor. Is there any tamponade there at all? Any no pulse?
No pulse.
Okay. Any answers yet, Ayman?
No, I don't see.
Right. Your 10 seconds is up. You're going to have to try again next time.
Okay.
All right. Carry on. All right. I'm going to stop the scenario there. All right. Okay. Because this could go on for a long time. Thank you very much, team. Now, we didn't script that at all. I had some idea in my mind. I gave them a few instructions. That was a sort of team scenario. We're specifically talking about communication in teams. There were some good things there. There were things that really need to be improved. So again, we want your feedback. What were the things that you thought were good, and what were the things that you thought needed to be improved? We need the man with the micro. Oh, you're going to go first. He got there first.
So in team communication, the team leader was doing very good. He was he assigned the roles and he was getting feedback regularly. But the team members, some of the team members were not following the closed loop communication. They were not closing the loop, and then some members were not very loud and clear. Even the leader was having difficulty in understanding them. So you have to be loud and clear.
Okay, that's a good start. Don't take it all, but that's a few importance. First of all, that the team leader was giving instructions and was giving clear instructions. I hope so, but they might not have been. Secondly, the team were very much being a passive team rather than an active team. All right? They were just looking, waiting for instructions. There are roughly two kinds of complex teams. There's vertical teams and horizontal teams. A vertical team is where you have somebody who leads and everybody waits to be told what to do, and when they're told what to do, they do it. A horizontal team is where everybody knows what to do and does it, whether they're told to do it or not, and the team works that way. And there has actually been evidence in resuscitation, specifically in trauma, where people actually published a paper on this and showed that a horizontal team is much more effective, that you achieve things much more quickly in horizontal teams. So you want a team where people actually aren't just waiting to be told things, but do things. Now, in fact, the team was doing it, but they were still just looking and waiting and not saying very much. As you said, they're very quiet. You also mentioned closed loop communication, all right? So this is where an instruction is given, and then somebody, so for example, can you give some adrenaline next time? And they reply back, yes, I'm going to give some adrenaline next time. If you don't hear that back, you don't actually know whether it's going to happen or whether it has happened. All right? So in this example, a good thing would to do say, I want you to give adrenaline next time. And then they say, yes, I will give it. And then when the next cycle comes along, they say, I have given the adrenaline. And I say, thank you very much, you've given the adrenaline. So if you don't have that closed loop, you don't actually always know whether something has happened. Okay, any other points that people wanted to make? Sorry, there's a microphone coming.
The team leader just keep the team all the time aware what he's doing. Okay, we got it.
Yes.
What he's thinking about the patients.
Yeah.
And he asked them if they have any opinion about what should be given. Just all the time keep them awake about the patients.
Okay.
What's going on?
Yeah. So there's two important points. One is the team leader communicating what the plan is, so that there is an opportunity for the team to say, actually, I think we need to do something else, but also the team know what we're aiming for. And this is particularly important when we're coming to the end of the resuscitation and we're thinking we're not achieving anything. So we know that we're going to stop in 1 or 2 or 3 cycles if nothing has changed. All right? And the second point was giving the team an opportunity, actively saying, what do you guys think? Give me some help. This is difficult. Please don't leave me on my own. All right? So there's 2 important points there. Yeah, another one.
Communication is not before the patient arrives, before the patient.
Sorry, what about it?
Communication is not before the patient arrives or the patient.
Yes, we didn't really go into much detail about that. It certainly would have been helpful if there are scenarios where you often do get information before the patient's arrived, and you can organize the team effectively so that people have clear instructions. Sometimes you get no warning, and you actually do that preparation as the EMS is handing over. So in this situation, I could have said, if EMS has just turned up in chest pain, I could have said, Ayman, you take over chest compressions, you do it, tell it to stop. Sif, you take over airway, and then get the handover or the endorsement from EMS. But there is no stop in resuscitation meanwhile. Any other important points you can think of? I can think of 1 or 2 more. Very good, isn't he? Yes, I was deliberately doing a mixture. I was deliberately sort of trying to use some names, but I deliberately sort of didn't talk to the resident's name. I could have said, and what's your name, if I didn't know his name. But it's a good practice to specifically talk to specific people by name. Because if you just say, give the adrenaline, nobody knows if it applies to them. So nobody does it. Whereas if you say, Hamza, give the adrenaline, there's no doubt who I'm expecting to do it. So that's a really good important thing. It's helpful to know people's names and give instructions to a specific person so there's no doubt who has to do it. Any others? Sorry, microphone, because I can't hear you as well. It's coming behind you, Rez.
And the voice tone was clear and short, and the clear progress as well. And clear delegation to do the orders of the system from the start.
Yeah. think that's about all I wanted to bring out of that. Thank you very much indeed, and thank you to the team.
Summarize this grand round and email it out to people who weren't able to attend today. So basically what we've done is we've run through many different scenarios. This is not a comprehensive list, by the way. I mean, for example, the scenario that we played last, there is a second part to this scenario where the relative arrives and we have to talk to the relative who doesn't allow you to stop CPR. Sounds familiar? So we actually played with these scenarios a lot more than what we have given you a little preview of. So what we would like you to do is to take away some of the summary points that we discussed, which many points that you came up with, and see if you can apply them in your practice. So I want to do a roundup of all the things that we have discussed for the last 1.5 hours. So starting with patient-centered care. This is about respecting patients' values and preferences. That doesn't mean we harm the patients by not practicing evidence-based care. What that does mean is we explain to them, we negotiate with them, we agree on the right plan of action. There are some do's and don'ts. Don't go first. Do not exhibit a negative body language. Do not ask the patient, why didn't you do this? Why did you come here? You should have gone somewhere else. I.e., don't blame the patient. And try to establish the patient's agenda, provide information. There is some good evidence that it improves patient satisfaction if you give them good information. And tell them about the next steps, give them discharge instructions. So all those good things should be done as much as possible. In history taking, what is focused history taking? The answer is it's not a brief history. It's more of a zoom in, zoom out type of history. Start with an open question, start closing in, and then open it again. And if you're not sure, try to probe and get some reflective questions in there. And see if you can listen actively, maybe 30 seconds. Most of us are about 10 seconds, so increase it very slightly. Maybe you would actually be able to figure out the patient's problem even earlier. And deliberately ask, are you concerned about something? Do you want to ask me any questions? Because what that means is the patient doesn't end up coming back to you or to somebody else as an extra time and an extra complaint, and we waste a lot more time dealing with those issues. So spend that bit of time explaining to them what's going on with them. So learn to ask questions more effectively, avoid being judgmental, and non-verbal skills, remember, show your interest, even if you're not interested, even if it's the end of your shift. So coming to de-escalation and negotiation skills that Dr. Khalid ran through with Amr and Hamza, I think the first step is really to gain control of your own emotions and prejudices. This patient X nationality is calling you, or they are going to be difficult. Well, they may be difficult, but they may have a difficult enough problem that makes them difficult. And always make a good first impression, offer help, say things, I'm here to help you. And show empathy and understanding, which means you acknowledge, look, I can see why you're here. I can see why you're concerned. I understand you're worried about this. And that reinforces them that they're not making it up. So practicing empathy is important, echoing what the patient says. You just told me that you're worried about chest pain. I understand. Identify their feelings. You seem frustrated. I'm really sorry about that, but let me just explain to you what's happening. And these are techniques I got off the internet. This is a blog that's very, very good, emergencymedicinecases.com. Some of you will be very familiar with them. We'll send out these links on email later on. The broken record technique. Repeat these empathic statements. Amr demonstrated that beautifully. He kept saying, sorry, I understand. Look, you might have a very important disease that we're trying to exclude. Keep saying that, because if they're very upset, they won't receive. They're not in the receiving mood. Act dumb, which means, please help me understand what you're saying. You said to me that you're upset about something. Please tell me why you're upset. I'm trying to understand here. And silence, if things get really out of hand, just allow things to calm down. Stay silent for a minute or 2 minutes. Allow them to diffuse and then start again. That's another good technique. So one of the things to think about is to give them options. Your options are, you can either just go home, not wait for your blood results, but you run the risk of this and that and so on. Or Give me some time, I'll fix the issues that you just talked about. And within an hour or 2 hours, you will have an answer to your questions. You will go home happy. You can go back and reassure your family there's nothing wrong with you. So those are your two options. I would recommend option 2. So something like that would allow them to make a choice and keep things simple. And don't worry about starting again. If things are not going well, just say, okay, look, should we start from the beginning? I just want to explain to you where it all started. Something to the effect. And at the end, give an action plan. Look, thank you for your time. I know it was hard for you for waiting for so long. But what we have agreed is as follows. And take some responsibility. Say something like, look, I will come back and review you myself, or I will hand over to my consultant colleague who will be coming to review you in about an hour's time. And if in the meantime you have any chest pain, please let us know so we can do something about it. Some more things about listening actively, speaking slowly, because they're not in a mood to receive you very well. Speak quietly if possible. Adjust your tone of voice. Learn from the masters like Dr. Khalid and Dr. Ashid and Dr. Amr. And practice good voice projection in loud environments. That's what Dr. Geoff is demonstrating here in the team communication, where you will have to increase your tone of voice. You will have to project your voice a little bit further forward so that you are actually audible to everybody. And if you're doing team communication, put some structure into it. It was quite interesting. I was talking to one of our colleagues, who's a fellow, who was doing short stay rotation recently. What he was telling me was it was quite curious to be at the receiving end of the referrals, because people are launching straight into, I've got a 50-year-old diabetic hypertensive with this and that. They didn't introduce themselves. They didn't tell him or her, the reason I'm calling you is because I've got a patient that could benefit from short stay referral who's got a community-acquired pneumonia. There was no IS to the ISBAR. So before you go into the background, tell them, what is it? Tell them a summary. And then, of course, finish off with your own assessment and your own recommendation or the agreed plan. That helps. So, this recognizing your own stress is so important for us in ED, because we work in a stressful environment and things happen that trigger us off in the wrong direction. All of us have experienced it. Some of us experience more than others. Some of us seem to have techniques to calm ourselves down. That's okay. Tell your colleague, look, I'm a little bit worried about something. Just give me 5 minutes. I'm going to go cool down. That's okay. But don't do that many times in a shift. Address the problem as a common problem. With that medical registrar referral, look, this patient is coming to medicine anyway at some point. So you and I have a common obligation to sort this patient out. And I'm here to help as well, but I'm asking for your help. And you don't always have to agree. We can agree to disagree, but agree on a plan that will work most of the times. For tips of critical communication, when I was putting together these slides, I was becoming aware that a lot of times communication in critical setting starts well before the critical event has actually happened. You're not going to get along with your lead nurse or your junior colleagues or senior colleagues if you haven't introduced yourself to them at the beginning of the shift. So start with nice things. If you say, look, I'm so-and-so, with a smile, looking confident, apparently gives you confidence. Looking relaxed apparently makes you relaxed. So listening to the viewpoint of your team, take an opportunity to teach even your nursing staff. If you're giving orders to a nurse saying, look, I want fluids in, I want antibiotics, and I want this in, you could also take an extra 10 seconds to explain to them, look, I think this patient is in early sepsis, and if you do not get these things in, this patient will deteriorate and may actually end up becoming much worse very quickly. So I do hope you recognize how important this is. So let's get that in within the next few minutes, and I'll come back to check on you. So be patient. If people don't receive your message, don't worry about repeating them. It's okay. And documentation is a very important form of communication. You've got to document clearly what your plan is. That allows the next team to pick it up. That allows your verbal communication to work better as well, particularly if a critical event happens after. During a critical event, watch Dr. Geoff and learn. Stand tall, project your voice clearly, know your team, allocate tasks. You're going to be doing this, you're going to be doing this, and be clear with your orders. And if there is lack of clarification, don't worry about it. Just clarify it again. And if you can articulate your priorities, look, in this patient, we've ran through the 4 H's and 4 T's. Our biggest priority here is hypovolemia. So I want all of us to focus on resuscitating this patient's fluid volume, and that is going to be our next step. So define it clearly. And after a critical event, and I think this is also important, just acknowledge the team's contribution. Okay, we don't have time. Okay, there is another patient in cardiac arrest. Okay, you can't do it straight away. Do it at the end of the shift. Offer a coffee. And some of those of you who work with me would remember that I offer you coffee, but I never buy you one. But at least offer a coffee. And ask them, look, do you want a few minutes break? We're still busy, but I think we can afford to lose you for a few minutes. So, care, document again, don't forget about it. So the reason we had to round all of these points is because these are all discrete little things. But if you put them all together, it makes your patient journey smoother and much easier and much safer. And that brings us back to the original point Dr. Ashid was making about patient journey. We are here to make the patient journey better. And by deploying good communication skills, we can do it that much better. And that is important for a lot of our patients. I think I'll skip the question part because lunch is waiting. And I'd like to thank all our actors, our camera crew, organizers, and the ideas from the faculty. All these case scenarios that we developed was a result of brainstorming over a number of weeks. And we will send you further resources on email. There's some very good links that you can read, you can listen to. These are podcasts. And I think this is something that you will have to stick with for your career. None of us have excellent communication skills by default. Most of us are good at some areas, but not so good in other areas. So keep working on them, and I hope you enjoyed your session today. Thank you very much, and enjoy it.